Hi, everyone. I am Sandra Whitehead. I am the current president of SOPHIA, which is the Society of Practitioners of Health Impact Assessment. And today I'm going to talk about the next section in our HIA How-To series, Recommendations and Reporting. SOPHIA, for those of you who might not be familiar with it, is an association of individuals and organizations that provides leadership and promotes excellence in the fields of HIA and health and all policies. We develop resources to develop and build capacity to do this work. We support member networking and peer mentoring opportunities, and we also communicate timely information on resources, training, and technical assistance opportunities. You can join SOPHIA for a very low price at hiasociety.org. As I mentioned, I'm Sandra Whitehead. I am the current president of SOPHIA, and it's my honor to lead this organization, as well as to be the program director of the Sustainable Urban Planning Program at the George Washington University here in Washington, D.C. If you're interested in our program, which teaches urban planning through a climate and equity lens, you can sign up for our student-run podcast at the link on the slide. So today we're going to recap a little bit of the activities that take place in the assessment phase of HIA, because part of our talk today, our recommendations really flow from the assessment phase. And I'll talk a little bit about 3 different techniques for co-generating recommendations with your community, and then integrating community narrative as evidence to drive your recommendations, as well as things that you should think about in the reporting phase of HIA. So just a reminder for folks who are new to the series of what HIA is. It is a flexible 6-phase process, and we use the word phase instead of step because a step is discrete and a phase is iterative. So just because you get finished with the scoping phase of your HIA doesn't mean you're not going to work with your community and revisit some of those decisions as more information is gathered through the process. HIAs explore how the impacts of decisions or policies, plans, or programs might disproportionately impact different groups, such as racialized or racially marginalized communities, lower income communities, those who are geographically or socially vulnerable. And it makes recommendations. A lot of assessment processes identify issues, both benefits and risk, but HIA is different because it really makes recommendations to maximize health benefits and minimize health risk. Just kind of a refresher on the different phases of an HIA and sort of where we are with this video in the process. So as I mentioned, recommendations really flow out of the assessment phase, and you should really work with your community to take the assessment data and decide what it means and how that should inform the decision going forward. And then I'll talk a little bit about reporting and different ways that reporting can be done. So just a kind of a refresher on the assessment phase. Assessment is really whenever we look at the evidence, and there's a lot of different kinds of evidence, right? There's evidence about the baseline conditions, both population-wise and built environment-wise, policy-wise. There's evidence of impacts that have already occurred, the part of that existing conditions where you're looking at maybe structural racism or other influencers on what is. And then you're taking those baseline conditions and the policy, and you're projecting the impacts on public health and characterizing those and discussing how certain you are that those impacts are going to occur and over what distribution and what geography over time. So, thinking about how this process plays out, I want to bring up again, really thinking about how to involve your stakeholders in the assessment and reporting phases. In assessment, your stakeholders, your advisory committee, your people on the ground, your impacted community should be helping you to interpret the findings of your assessment phase, to generate with you, not for you, but to co-generate recommendations and advise on local knowledge. And what I mean by advise on local knowledge is to tell you, this is this thing that you're saying the data tells you is the recommendation and the thing that you should do to keep this from happening again. This has happened over and over, or we've tried this and it didn't work for these reasons. So really having those on the ground folks to tell you what's feasible, what's advisable, and what is just not going to work from the community's perspective. Because if your recommendations don't work from the community perspective, they're not valuable at all. And then there's also roles for your stakeholders in the reporting phase to look at the documents that you're putting out, whether that's a video or an HIA report or some other kind of HIA product, and to say whether these ring true, whether there are edits that need to be made, and to help you with the presentations to the decision makers. So thinking about how the community plays a role in this recommendation phase, really they help you ground truth your findings, right? And which your recommendation should flow from your findings. So if your findings are that people already have an increased risk of asthma because of these two polluting land uses, and people do not want more polluting land uses, then your findings should ring true to the community. And making sure that you're being completely transparent about how you came to these recommendations, about what the data says, making sure that you're ground truthing your data with the community, but also that they are buying into the process, that they feel included, that their voice is reflected in the HIA, which will give them, which will give you support, not just for the recommendations, but for the follow through, for the implementation phase. If the community has been involved and are and have been co-authors of the recommendations, then they have a better stake in making sure that the recommendations are followed through and monitoring progress at the local level, when you as the researcher might be long gone. So in just a recap of the findings, right? What your findings in an HIA should cover are these 5 aspects. The direction of changes, will they be positive or negative? How likely are these changes to happen? Is it 95% likely? Is it 5% likely? Is it very likely, right? Sometimes we can't give a confidence interval reliably. So we say things are likely, very likely, or less likely, because we might not know, right? Our uncertainty might be high. Excuse me. Magnitude. How widely will these effects be spread across the population or across a geographic area? Are they are these impacts only going to affect children or only going to affect elders? Will it be across the entire city population? Will it be in one neighborhood, right? So figuring out who the impacted population is and the magnitude of it, and then the severity. How severe will it? Will it be life-threatening? Will it be permanent, cause permanent damage? Will it just be occasional whenever there's a lot of ethyloxyline that is released? Will asthma impacts go up on the days that the releases are high, right? How severe will it be? Will people go to the hospital? Will people die? And then the distribution is a little different from magnitude, because the distribution identifies the subgroups and subpopulations who will face the most disproportionate impacts. So whenever you think about your findings, And they show up in a table that's kind of like this. You know, it has your likelihood, your magnitude, your severity, and your vulnerable populations defined. Then you want to, and just here's another example of an impact table that shows this is the public health impacts from emissions reductions and basic access of impacts of different kinds of transportation. And making sure that you're interpreting these findings with your community, not just explaining it to them and talking down to them, but saying, does this seem real to you? Do you see uptakes in asthma attacks in your children or in your family when there are big release days from the water treatment plant or from the ethoxylene plant, right? And this process of really interpreting the findings and making sure that you're talking with your community about them and making sure that you're including community perceptions of the issue at hand. And those are really come together in this co-generation idea. And so there's three kinds of what I think of as these co-generation techniques, right? Thematic mapping, which is very simple kind of idea mapping. Iterative convergence, which is how you use the community data and how it comports with the quantitative data, and then community voting or ranking. And I'll talk a little bit about each of these. So thematic mapping, you might have also heard it called mind mapping. There are some tools that are web-based tools that are automate this process. I prefer to do a very simple kind of mind mapping as people are talking in a community meeting. You start to put the big ideas or the themes in the bubbles, and then invite people up to say which ideas come off of those bubbles or those themes and what they'd like to see in the recommendations. So say one of your themes is ensuring that the community is notified on high pollution release days and that the community has 24 hours of notification so you can wear masks or stay indoors and or warn children to not play outside that day. And so that might be one of the bubbles is community notification. And then coming off of that would be the different ways that people in each subpopulation receive messaging. Maybe it's the parents receive messaging through a text stream that comes out through the school system. Maybe elders receive messaging through the Amber Alert system. So different kinds of mapping styles can be used also. It doesn't have to be bubbles, but the idea is for people to be able to see their ideas reflected on the mind map and how it relates to other ideas as you're developing recommendations. The convergent method of integrating community narrative is where you're taking testimony from the public, from the impacted community, and you take the testimony and you map it out thematically, and then you match those themes back to the quantitative data that you've received. So for instance, in my example about air pollution, the community says it's not just on days that they've said that they're doing a high release method that we're having issues, right? So taking those community days that they have mapped, and oftentimes community members will keep a diary and bring that to the meeting, and mapping that against the days that the plant might say that they're releasing versus where the air monitoring data, the air now monitoring data says that the releases are. And taking that and merging those two things together, the quantitative and the qualitative together, so that they're not just validating but they're reinforcing. And where there are anomalies, then you bring those up where the data don't match, the community perception and the data don't match. Then that's where you start your conversation around community recommendations. So this is the convergent method. Voting and ranking is by far the most common method where small groups of stakeholders will sit at tables, oftentimes, or in Zoom rooms, and generate themes and recommendations. And then those go up on a virtual board or a whiteboard, or even I've done it with flip charts. And you put those up, and community members rank them. And the ones that aren't ranked high, you discuss as a large group. And then you do this iteratively until you have the themes and the recommendations that you've built consensus around. So these are just three methods of consensus building. They're by far not the only ones, but these are just three that you can try in your HIA and HIA work. And now I'm going to talk a little bit more about integrating narrative into recommendations. You know, when we think about how we form recommendations, right, and how we think about evidence and data, there's this pure data that we were all taught in school is the highest rank of data, right? It's you've done a double-blind study and you've done experiments and you've got a control group, an A and a B, right? And that data is like the purest kind. And that data gets turned by interpretation into information, and then the information becomes knowledge. And in HIA work, it doesn't always follow this hierarchy, right? You've got some data and you've got community knowledge and you've got some information, but bringing it all together and making sure that you're overlapping it to validate community voice. And if it doesn't work together, figuring out why and talking that through is very important. So you always want to make sure that your recommendations are driven by the findings. And HIA is a scientific work, and making sure that your data backs up your recommendations. Because a lot of times communities will say, well, you know, we think you should tell the plant to, you know, shut down 3 days a week, and they shouldn't be, you know, they should only be emitting ethyl oxalate 2 times a week. Well, that's not always feasible, right? So looking at the data and saying which days is there poor air quality already, and maybe having the plant switch its days that it's emitting based on air quality and inversions or the particular geography of that place. Right, that's a different way of looking at it, but making sure that there's a backup of some type, whether that's community narrative, whether that's, you know, citizen science data for every recommendation that you make. And then, as I mentioned, there are different kinds of evidence. You know, the formal, scientific, quantitative, published in a peer-reviewed article data is not always there yet, right? It's not always where people know in their heart they're being impacted. So there might not be a double-blind study or preponderance of the evidence that says that these are true impacts. Other data sources that we want to make sure that we're including are professional expertise. So making sure that the people who are implementing whatever this decision is, the regulatory folks and the regulated community at the table, making sure that we're considering lived experience. And I don't just mean lived experience of one person, although that is important, but how lived experience becomes community narrative. It's that validation, that sharing, and that building of a narrative of what it's like to live in this community, that we're acknowledging and respecting that, and making sure that this community narrative and traditional environmental knowledge, this knowledge that elders may have had who've lived in this area, you know, for generations and passed down to them, that we're validating that and making sure that we're considering it. Because a lot of times science can come in with a solution, and our traditional knowledge tells us that the solution isn't going to work for a variety of reasons. So making sure that we're including all different kinds of evidence and acknowledging and weighting that. And when we're prioritizing our recommendations, making sure that the communities that are affected by the proposal are that the recommendations are responsive to their needs and appropriately address their concerns. Whether or not, you as the researcher think that this is a good idea or that this recommendation, is feasible, that's not always up to us, right? So making sure that the implementers are included in this conversation, and that the recommendations are effective once they're implemented. And this slide comes straight out of the minimum elements and practice standards, making sure during this prioritization process that you have clear criteria and that you've documented your criteria for why you chose some recommendations and perhaps not others. It's perfectly valid to reject some recommendations, but it has to be documented as to why. And then just following up on my comments around evidence, right? Just making sure that we are considering all different kinds of evidence and that it's validated and triangulated. One of the pushbacks I get about from people who are like, I would love to use community narrative, but this HIA is being used in a regulatory context, and I need to be able to have my decision hold up in court. Well, there are ways of integrating community narrative that will hold up in court, as far as taking public testimony and documenting that testimony and ensuring that you're clear about how you're weighting it in your recommendation phase. So it can be challenging, but it's doable. Don't let people tell you that community narrative will not hold up in court, because that's just not true. And then whenever you get your recommendations, thinking about how you're going to communicate those recommendations. Traditionally you'll see the 200-page HIA report that's got charts and tables and detailed explanations. And while those are great, those are primarily written for other HIA researchers. Other kinds of work products may be more appropriate for your decision makers, depending on, or your community, depending on where you're at, how complex your HIA was, whether or not there are language barriers. But other kinds of work products that can be used are having public meetings and communicating those. Also thinking about different ways of what you need to communicate in your HIA report. And it doesn't have to be a full report to communicate all of these things, but somewhere in your communication, you need to talk about whether or not there was a sponsor for your HIA and be clear about your funding source, because that, if you're not clear and upfront about that, that might call some of your recommendations into question and your motivations. And then make sure that you're listing everyone who was on the team who contributed to the HIA, noting whether there were any conflicts of interest, who the community participants were, making sure that you've noted your outputs from the screening and scoping processes, that you have a summary of your stakeholder engagement strategy. Who did you talk to at what point in the process, and what was the outcome of that? Documenting what assessment methods you used. How did you come to these conclusions about your data? Your recommendation development and prioritization process, what did that look like? And last but not least, your evaluation plan for your HIA. A lot of times we will primarily focus on process evaluation, because most of the health impacts are several years out from being felt. So, and we will do a follow-up report, a webinar on evaluation planning. But thinking about your dissemination methods, as I mentioned, that like this particular HIA that I have the cover of here, this is a long report. It's not 200 pages, but it's pretty long. But making sure that your dissemination strategy covers everyone and all of the communication styles that you need to cover, whether that's translating your findings into different languages, whether that's doing a video or publishing fact sheets or one pagers about your findings, taking public testimony or giving public testimony, having your folks from the community, from the impacted community, give public testimony is often very effective. Newspaper and magazine articles, not as much, but online forums like blogs and video logs can be very effective communication tools, depending on your audience. And making sure that as you're thinking about dissemination, your HIA materials are they're easy to read. They're in the appropriate format for your audience or audiences, and thinking about you might want to do something different. Say you're doing a video for the community, but you might want the full HIA report, both for your funder and for the decision makers, or your decision makers might just want an executive summary. So thinking about how to make that readily accessible in the appropriate format, and making sure that that it's accessible both digitally and by paper if those are the needs of the community you're serving. I want to thank you all for joining this webinar this afternoon, and to apologize for our technical difficulties. We do have two upcoming webinars in the next couple of months. In September, I'll be presenting with Christine Ortiz-Gamina about the Health and All Policies Preparedness Guide that she and I created for NEHA. And then in October, I'm very excited to welcome Dr. Benjamin Pauly of Kettering University to talk a little bit more about using community narrative as evidence. Thank you so much. And I invite you, if you enjoyed this webinar, I invite you to join SOPHIA. Thank you.